Hello and a warm welcome from Metal Headquarters here in Innsbruck, Austria. My name is Peter, and once more, I have the honor of hosting this surgery online session today. Today, we're going to be looking at two speakers, which I'm going to be introducing to you in a second. And today's topic is going to be how to perform your cochlear implant surgery, lessons from two experienced surgeons. Before we start, I would just like to, as usually, go through our obligatory housekeeping slide. If you're joining us from any computer or a smartphone, please, if you could just click on your name and rename yourself with your actual name and maybe also the city or country you're joining us from. To avoid any background noises, it would be great if you could maybe mute your microphone throughout the session and mute your phone as well. And of course, for a smooth and stable internet connection to actually enjoy our today's session, it would be great to maybe close down all your programs on your device. Please feel free to comment or post questions at any stage. We're going to be actually addressing any questions at the end of the session. Good. So like mentioned, we are having two speakers today, which is very exciting. And without further ado, I would actually like to welcome Professor Gunesh Rajan from Lucerne, from the Kantonsspital in Switzerland, and Professor Robert Mlynski from the Universitätsmedizin in Rostock in Germany. Gentlemen, welcome, and the stage is yours.
Thank you very much. Great to be here.
Thank you very much for the introduction. Professor Rajan and me, Gunesh and me, will take you through our concept of cochlear implant surgery. We will talk about certain steps, how we categorize our surgery and discuss it, how we both do it, and we hope we help you addressing certain aspects what makes sometimes the life difficult. So I'm going to share my presentation, which should be seen now. Okay. Gunesh, where are you from?
Good question. I keep on wondering sometimes. At the moment, I'm in Lucerne, in beautiful Lucerne in Switzerland. As you can see, it's a great place, great views. The hospital, it looks iconic, so you can see on the picture, right? So I've worked in Switzerland at the moment, but I worked for a long time in Perth, Australia as well, which I call home as well. So how about you, Rob? Where are you from?
Yes, I'm from the other end of Europe in the north, in the top of the north. Rostock, it's called. It's always sunny, as you can see here, and never rainy. It's at the Baltic Sea, and Rostock is known for Otto Körner because he was the first one heading an ENT, otorhinolaryngology department, and being a chair at the university for our complete subject. This is the hospital. He was awarded in 1899. It's the same hospital we're still working in. And most of you know Otto Körner because of the Körnersches septum, ossified petrosquamous suture. But let's do some cochlear implant surgery. First thing comes first. Patient has general anesthesia, is covered, sterilized, wrapped, and we use infiltration anesthesia and then plan our incision and position of the implant housing. The aim of this is to have distinct distance between the coil and the auricle, so we have no contact of the speech processor with the implant and with the coil. I personally prefer the Lazy S, so I have lots of space. I don't need to replace my retractors. That saves some time. How about you? What are you doing?
Same, yeah. I also use the Lazy S, and obviously try to develop, the skin soft tissue flaps, so at least have a double layer. I think that's an important feature also to prevent, infection and extrusion. Do you do it differently in children and in adults, Rob?
No. Actually, same as you. I always try to have opposing flaps for skin and muscular periosteum, so we don't have a direct trajectory, or what is it? A direct
Communication.
capillary system towards the implant. Yeah.
Yeah. So is your periosteal flap anteriorly based or posteriorly based?
Posterior, superiorly.
Yeah.
So the skin flap inferiorly and the muscular periosteum flap cranially.
Yeah. Same for me. Yeah.
We don't do usually drawings. That's just for illustration here.
Yeah.
So we have a 45-degree out of the temporal line, which is also important, and to have enough distance between the coil and the processor.
Yeah.
Okay. So
I think, it's funny. I mean, there's so many different kinds of technique, and it's incision wise, shape wise. But I think the important thing is, as you said before, is have it several layers to protect the implant. I think in the end it probably does make a big difference as long as you stick to those principles. Yeah.
And watch your patients. I mean, it's plain functional surgery. We always keep in mind it's plain functional surgery. So we do not want to have any infections causing complications. And then we also have to think of, especially in children, that we have to do several times surgery.
Yeah, it's during a lifetime. Good point. Do you use antibiotics? We do a single shot, for these implant surgeries, and then usually not, don't give any more antibiotics. How about in your unit?
Yeah, single shot, second generation cephalosporin, which is CSF transferable, and this is about half an hour prior to surgery. So once the patient is intubated, the anesthesia, the antibiotics goes into IV.
Yeah.
Shall we look a little later? I mean, the problem always is if you draw a picture on the patient, and once you have placed your retractors, which I think is also important, how to place the retractors so you have always maximum view on the temporal bone. How to find this position back on the temporal bone. I think it's important to identify certain landmarks, which is of course handler spine. I also think it's good to have the tympanomassive fissure identified, then the temporal line, and the sutura parieto-mastoidea gives you also a good sign where the aeration stops. So if you place the implant housing, let's say with 2/3 posterior to the suture, you always have sufficient distance to your anatotomy and mastoidectomy defect. And it's also, it's an individual landmark. If there's no malformation, if you have a normal skull, if you do bilateral implantation, you can also use this system to identify the exact spot on the other side. 45
I think, I think the landmarks are really crucial. And especially if it's a normal ear without any malformation, I think it's really important to stick to the Henle spine, identify the posterior canal wall skin, temporal line. I find the parieto-mastoid suture quite useful, as you said, because that tells me where the aeration stops, right? So if you place the receiver behind that, you're safe and you're not in the aerated area. So I think that's really also good, good anatomical help landmark.
If you continue preparating your periosteum pocket, you should be aware of the asterion, which can be opened. It's a drainage to the sigmoid sinus and transversal sinus, and can cause lots of bleeding. Bleeding can be stopped with a diamond burr and without irrigation, or Knochenwachs. Bone
wax, yeah. The emissary veins, there's so many variations of the emissary veins, but using the technique you said with the burr without water, or using some bone wax, it really solves the issue. Yeah.
And let's go to the bone bed. Do you do a bone bed? We don't want to have the implant rocking, which is important.
Yeah, definitely do a bone bed. Try and drill it as sufficiently deep, because we want to prevent migration of the implant. So at least do it 3 to 4 millimeter deep, especially the anterior bit. The processor part, the anterior part, needs to be well recessed, as you're showing.
This region, yeah? Yeah,
exactly. And the anterior ridge, I think that's a crucial component, and in children, I also trying to do that, which sometimes means, obviously, the children have a thin bone, cortical bone. So sometimes you have to drill down to the dura, but I make sure that, I leave a bony island on the dura. How about you, Rob?
Yes, the dura shouldn't be exposed completely, and especially in children, sometimes you will have a little piece of dura exposed, because the angulation of the skull is sometimes very, there isn't much flat size. And then I do the bone bed always before the mastoid work. So because it's the most boring part, but it's an important part. So I take care in the beginning, and I don't have to bother later on when I have everything finished. I just can fix the implant and then insert the electrode. Sufficient deepness you mentioned. You said that in the beginning, at the anterior edge, there can be up to 3 millimeters. And if you look at the levels of the implant, you have the coil here, and then you have the electronic package. And there's also a little ridge, and this is less than 1 millimeter. So there's no need of having a deep bed towards the coil.
Posterior part,
because it is angulated. We don't want to have the implant moving like a caterpillar on the skull. You always have to think of that. The temporal muscle gives, every time you chew, gives a force on the implant. Then the coil being placed, giving also stress to the implant. So, and the patient shouldn't have it every day somewhere else. First thing, and second thing, if it moves, at the place where it moves now, you have seroma or hematoma, and this can be causing infection. So I think implant should be very good fixed. Shall we continue?
I totally agree. I think in children as well, if you can make the well as deep as possible, also it doesn't stick out too much. So, it's less susceptible to trauma, because it's a big issue in the children. And, I think that's a good way. What are your thoughts on the pins? There's some nice, devices actually, which are pins.
To be honest, I haven't been using the pins since the introduction contract, when it was introduced with the contract. And I was using it with the Synchrony 1, but with the Synchrony 2, I haven't been using it anymore. But the templates and things are much more thought of now. So you can easily, if you do just a periosteum pocket, you can now nicely use the drill to do the indentations. Are you using pin implants at the moment?
No, not really. I'm just concerned, if with the pins you place the implant on the bone, right? And then I'm concerned what happens with the lead, because if that stays on the bone as well, you have all this risk of shearing injuries, the micro shearing over time, which can lead to to an implant failure. And if you do the pins and then recess the lead in a canal, you have this step between implant and the lead. So this kinking. So I'm not sure how good that is for the lead in the long term, mid to long term. But I haven't, so I don't regularly use the pins.
That's very important. The lead should be in a channel towards the mastoid. We will come to this later, and there should be no conductor link or lead outside of the cortical plane, lateral to the cortical plane, because every movement will be transmitted to the electrode.
Yeah, I think that's a thing. Initially, when I was starting cochlear implantation, I wasn't really aware of that. You know, these micro shearing injuries of the lead. If you just place it on the, but it certainly has, now we know, you know, it has an impact with regard to implant failure.
Yeah. So next step would be anatomy and mastoidectomy. So
exactly. Yeah. So if interesting. You know, you said you drilled the well before the mastoid. I did the opposite. So I drill the mastoid first and then do the well. But I see your point. You know, with regard to the workflow, I think that it's a good idea. You know, doing the well first and then the mastoid, because then you can, after you've done all the drilling, you can just switch to the implant and don't have to worry about drilling or anything. Yeah, that's a good point.
Everything is prepared. And
yeah.
Another aspect why I do it first is you don't have all the bone dust. You know, when you have
true.
I do seal the posterior tympanotomy anyhow, because sometimes you need to drill the groove for the conductor lead.
Yeah.
If you do the bed, you have all this bone dust going around and floating into the in the mastoid doesn't matter, but in the tympanic cavity there shouldn't be bone dust.
Yeah.
Okay. Yeah. Shall we do a mastoidectomy or anatomy?
Yeah. Let's go for it.
Okay. Yeah. So landmarks for anatomy, cranial is your temporal line. First thing to identify is the middle fossa dura. You should leave obviously bone on it. And in my opinion, it is very important to start in the cranial third of the outer ear canal. So this would be head and spine. So this is the middle part, and the inferior part can't be seen here. But you have to go towards the zygomatic process of the temporal bone, and you should be towards the roof of the outer ear canal. So you will be very easy when you follow this triangle medially along the dura and the outer ear canal. You will end up with the horizontal and the incus. It's very speedy and very safe. So that would be the first step for the procedure.
Do you do this under the microscope or without a microscope?
This can be easily done without a microscope. For beginners, I would probably recommend to do the first step with a Rosenburr drill of the cortical bone. And once you identify the first cells, you switch to a microscope. And once you have a further routine, you can even do it without microscope. If the anatomy is regular and you have yourself convinced on the CT scans about a good aeration.
Yeah. And I think one important point, you know, if you're doing chronic ear disease, cholesteatoma surgery, you always are, you know, I was taught to saucerize the mastoid bowl, but actually we don't want that in cochlear implant surgery, because we actually want some overhanging edges so that you can recess the lead, you know, from the coil to the implant to the array. So that's a bit of a different kind of mindset when you come from chronic ear surgery. Yeah.
On chronic ear, you want to have a funnel what is larger in the lateral and smaller medially. Is that correct? Yeah. Now you want to have a little bony cortical overhang, so your loop doesn't go cortex. The cortical bone. Yeah, that's an important point. So what's also important is you don't need to destroy all the mucosa. I mean, this is the bony lung of the mastoid, is the air chamber of our temporal bone, and we don't want to mess this up. I think also plugging it or things is not very advisable, because it will interfere with the delicate pressure change between the tympanic cavity and the mastoid bone. How's your opinion on this?
Yeah. Well, preserve as much mucosa as you can, because it's also clearing. It clears, everything. So it has an important role. And obviously, it's also important for the gas exchange and all that. So that's something, we didn't realize like 10, 15 years ago, right? So, yeah. So,
also important is when you do your anatomy, it's really stick to the dura, because this I often see in revision surgeries that there's an anatomy around here, so in the middle of the outer ear canal. So this is actually the most dangerous point to do an anatomy, because there you hit the fossa incudis, there you hit the semicircular canal, and there you will hit the facial. So if you stick up here, this is much more medially than the fossa incudis, and you also don't risk to touch the short process of the incus with your burr, especially if it comes to residual hearing. If you touch the bone, the incus with the burr, you have no more residual hearing.
And do you also? We always use facial nerve monitoring. Is that same with you guys? Or?
No, we use it only in malformations.
Okay.
Otherwise, routinely not.
Because we tend to use it because obviously we train we have people training, so to have that extra, monitoring. And obviously in malformations, with the aberrant facial nerve, I think it's very important.
Always malformation. Always, we do it in all facial surgery, facial nerve surgery, neuromas, parotid, or anastomosis, and things like this, or paresis if you have traumatic. So, but for routine cochlear implantation, usually not. But in training, we really have structured identification of all these landmarks, and then and this is supervised. If you hear the monitor but with the burr, it's probably the same as it's gone. It was the last thing you hear from the facial, isn't it? If you have a Rosen burr and you hear your monitor, burr.
Well, it's not. You can't rely on the. It's just a tool, as I said. You have
nice to have it.
Anatomic landmarks. It's just an safety, additional safety. Shall we do the posterior tympanotomy?
I would recommend so. So let's do it. So posterior tympanotomy is exposition. So you have a subtotal mastoidectomy. Yeah? You don't need to drill out all aerated cells, but you have to identify the facial and quarter, and then you drill out the quarter facial angle. And the cranial border is fossa incudis, anterior the quarter tympani, and the facial posteriorly. You saw here beneath the burr the retrofacial cells, which is also a nice landmark to have. And I recommend really to identify the facial in the quarter facial angle and not in the outer knee, because this gives you safe space to drill out the posterior tympanotomy. You have the pyramidal eminence, Dapius head, posterior arc, and then you have the round window niche.
Yeah.
If ever possible, you leave bone on the facial. Also, in this situation, drilling in the recess, in the facial recess, is watch the
shaft. The shaft of the burr. Yeah, exactly.
You get heat problems here.
You don't want any thermal injury on the facial nerve. I think this is actually a good point. Obviously we want access. So that's what you already think now is we want access into the round window niche, right? So that means we also need access, for the instruments, for the implant. So that's the working space. But what we also have to think of is we want light in there as well. So I think that's also something to keep in mind. So you have to drill away enough bone so that the light can also get into that area. And that's why thinning down the outer ear canal, the posterior canal wall, all these things help, and making use of the whole facial recess.
Yeah, I think this is a very important point you make. I mean, you have two instruments, the electrode and you want to have enough light for both of your eyes in this posterior tympanotomy, especially if it comes to soft surgery and atraumatic surgery.
Yeah.
If you do round window surgery, so there should be enough space, there should be enough light, and you know there are physical aspects. I mean, if you have only a spot for a spot-like aperture, you have lots of deepness of focus, but you don't have any light there. It is being bent and it's being diffused, so you need light there. This is very important, especially if you grow older and your lenses get blurred, you know.
Yeah, I think that's what I tell my fellows, you know, obviously, you know, just don't think, and the other aspect, already now think about the trajectory. We'll talk about that later on, but already now you have to think, which way am I going to introduce the electrode? It's from posterior, you know, posterior superior to anterior inferior. So already think about that trajectory as you're drilling the posterior tympanotomy.
That's important because our electrode will be directed by 2 points. The first point is here, entrance in the cochlea, and the second one is where to grab it with the forceps or with our forwarder. And this is the 2 points, and these 2 points give a trajectory.
Yeah.
So let's talk about how far to expose the round window membrane. Although first, before we open the round window, I do fix the implant actually in the groove we make, and we have the recess, the full recess of the electrode in the canal.
Yep. I
tie it down with resolvable thread. So it's 3 months, it's being really tied down to the bone, and then fibrosed pocket will have developed, and then I think it's fixed.
So you do this for children and adults?
Yes, always.
Yeah. Yeah, I do. I also suture it down, but in children. Yeah, but I also use non-resorbable as you usually sutures. Yeah.
No, resorbable. I do use resorbable.
You resolvable. Yeah. Yeah.
Because when I do revision surgeries with where patients were tied down with non-resorbable, the thread is also in bits and pieces everywhere, but it's not a continuous thread anymore. So it's there's no point in using non-resorbable because it's I use resorbable. Did I make this point clear? Yeah.
Yeah. Same for me. Yeah.
So non-resorbable is no need. So round window. Round window. So this is now temporal bone. This is a not a human. Oh, it's a human, but fixed temporal bone. So left side, long processus lenticularis, pyramidal eminence. We have the promontory and facial and chorda, and this would be the space for cochleostomy, but we don't do this anymore. We want to have safe access to the scala tympani, and we want to have a trajectory. If we just we need to expose, I think, the membrane as much as possible, and this would be the way of the scala tympani, and this is the hook region which we want to preserve because the vessels of the endost and the spiral lamina are in the lateral inferior part of the scala tympani. So we use a slow rotating burr, diamond burr, and drill off the anterior and superior edge here. I always leave a little bony overhang in the posterior aspect because there and if you do the flex soft electrode, you have a little ring there, and this ring hooks behind this border and keeps your electrode inside. So how do you approach this?
Yeah, same. Really, try and expose, as you said, the round window membrane as much as you can. Because then you can also gives you more options regarding the trajectory, right? Especially again, if you keep in mind, we want to have the posterior superior to anterior inferior trajectory of the electrode. And obviously round window, insertion, and then we don't want to violate the endosteum, because one, obviously we don't want to drill. Also, we can injure those vessels you are talking about, but also we can, initiate these inflammatory responses through a cochleostomy, which we know will cause, or there's a high risk that they can cause, residual hearing, fibrosis, all these things later on, or loss of residual hearing, to be precise. So I think that's really an important aspect, to really have a control of your insertion, a really good view of the whole round window membrane. And interestingly, the best practice for that, I remember also with my fellows, was doing the round window vibrant sound bridge surgery, because there you learned to create the access, to the round window membrane and niche. So that was quite handy. Yeah. All right, so we've exposed the round window membrane. So what's next?
Yeah, I mean, if you mentioned the round window positioning of the FMT, I think it's also it's important to don't touch the membrane with the burr. Because if you have residual hearing, I mean, in a VSB, this is even much more important, because maybe you kick off the patient to a cochlear implant indication if you touch it.
Yes, of course, you don't want to induce a sensorineural hearing loss by drilling. Yeah.
Slow rotation. You can use a skeeter, for example, if you have, works fine. Yeah, trajectory you mentioned. I mean, this is extremely important, because the Flex Electrode series that's the outstanding design, where you can reach towards the second turn of the cochlea, but you also want to get there and don't have the electrode folded up in the middle ear or in the cochlea. So the insertion of the electrode is a crucial point. You need space. This is the most important step, to have easy insertion of electrodes. We had this with the posterior tympanotomy. And then second is, you want to have the electrode going along the lateral wall. So you don't have any tip forces on the electrode in its course, because this will cause fragmented friction. And this will, if you are unlucky, this will succeed, or will be higher, this friction in the lateral wall, then the friction or the compliance of the electrode, then it starts kinking. So this is important to have slow movement and the right trajectory.
Yeah, totally agree. I think that's so all the principles of soft surgery or structure preservation surgery, really. Yeah.
How about insertion of an electrode? Oh, this is an example. If you have, if you have too much, if you don't have your trajectory properly planned, you get into one turn, and then if you use force, you shouldn't have force. The electrode should be sucked in on its own into the cochlea. If you use force, then you do something wrong. You can have little force, and then the electrode extends itself. But if you continue pushing, you will get kinking. So let's see how we open the round window membrane. We do it under a fluid seal of balanced salt solution and a small 45-degree hook. So we now see the scala tympani, and here the hook region. And you should have, it should be open, because the electrode is getting a little bigger over further insertion. Then also you must keep in mind that the electrode, the openings of the metal contacts, there's a little, what is it? A little step around it. And if you have any like bony bit, or if the membrane is too tight, it sticks in and you cannot continue further. Slow is important. If you have students in the theater, you can ask for a medium-sized joke.
Yes, the
Couldn't be
happy
funny because otherwise you could start shaking.
Yeah, I think I do it the same way, really. Open the round window under fluid. I use steroids. I use the dexamethasone in the round window niche. Then basically open it up and then, yeah, slow insertion, as we know, to avoid, to avoid the intracochlear pressure change. I think one important aspect, you have to make the opening also wide enough.
Yeah.
Because we are pushing an array into a confined fluid-filled space. So if there's not enough space for the perilymph to egress, we cause quite dramatic pressure shifts in the inner ear. And especially for, in hearing preservation cases, that can be really counterproductive. So really, I think it's important to have a wide opening of the round window. What are your thoughts, Rob, on that?
Yeah, exactly. I think what you described is the Archimedes principle, where there's one space, one body, there can't be another. So the volume isn't too much. I think Claude Joly calculated, I've forgotten the exact number of the volume of the electrode itself. It's only a third of or even less of the volume of the scalar tympani, but yet the fluid needs to get out somewhere. So that's why important that you have some space around it, and then you seal it later on with some connective tissue. And
Yeah.
well,
So
yeah.
do you have to seal it?
Yeah, I think it's good to seal it because you have capillary forces, and it is you always need to keep in mind that this is outer space. This is environmental air, environmental mucosa. So there is it's the same as the outside. It's not sterile. Yeah, and
usually because I've seen quite a few surgeons say that the electrode seals off the round window niche, the opening, so it's tight. That's probably also one point, but I guess I think there's some ongoing studies that are looking to whether the infection rate is higher, but it doesn't appear to be, so which is quite interesting. Yeah.
I don't think it's a big issue. But we always have to be consistent in our argumentation. If you have it fluid sealed, putting something in a fluid sealed perforation, we will see this in a malformation. There it is necessary, but here we don't want it, because when we push it and that's fluid sealed, then we'll get all our force in the cochlea.
Yeah.
I think I always seal it, and we are in round window, but I think we should do, because of malformations and certain situations, we should be aware of how to do a cochleostomy. Because this is sometimes then the only approach to enter the cochlea if you don't have a regular case. For example, here there's calcification of the scalar tympani. So we continue with the inferior part of the long process of the incus, and we have 1, 2, 3 heads of the stapes. There we always get to the basal turn of the cochlea anterior to the round window. So you should also, I think, train this now and then in the temple bone, because just right now I come from a surgery where a patient couldn't be implanted because the basal turn was obliterated. So the previous surgeon stopped the surgery, and then we did it. Now we do a cochleostomy, and it's no problem in insertion the electrode. Yeah. Okay. So malformation. Here you see a large vestibular aqueduct. Yeah. Cochlea and cochlear aqueduct, and there CSF comes out in the oozer. How do you deal with this?
Yeah, usually, head up position. Positioning of the patient is helpful, and then you wait. Usually an oozer subsides, and then you can implant it. After a few minutes, you wait, and then probably choose the right size of the electrode so that it can seal off the the opening, and I think that usually works well. And I think we also have a situation of a gusher. Usually these principles also work in a gusher.
This is the tricky part, because if you have a malformation, let's say IP2 or IP3, then you sometimes need smaller electrodes and you don't know what to do. Will you fit in? You can, of course, check with the Autoplan in advance. But we also have the malformation electrode. So there's quite a portfolio where you can choose how to approach this individual case. So sometimes if I'm not sure with Autoplan decision, and for example here IP3, X-linked deafness, with a real gusher where the CSF comes out, then you can use an insertion or insertion probe. There's many insertion test device. There are like at least three different test electrodes where you can see how to operate with the cochlea, or manage the cochlea without opening the actual implant yet. And
yeah, I find those test or insertion electrodes really useful, in malformations, but also in situations where you have ossification, for example, and you're not sure, how far you can introduce the electrode. So using insertion electrode is very handy in those situations. So you can choose the right electrode to put in afterwards.
Yeah, even if you have like beginning of fibrosis, if you have a meningitis case right away, even then fibrosis can start. Then their insertion test device is nice because it's a little stiff. There's one filament in it. Or now there's also a stiff probe, which is really stiff. So you can, even if you have like an Haribo jelly bean kind of fibrosis in the cochlea, you can slowly separate the fibrosis in order to get electrode inside.
Yeah. All right. So
sealing and fixation of the electrode. I think we already started this discussion. I use temporal fascia or
periosteum
from the temporal bone in order to seal it.
Yeah, usually I also use some periosteum or some temporoparietal fascia, something thin, which can really also mold.
Have you ever experienced ossification if you use periosteum around the round window opening?
Not really.
I haven't either, actually.
I can't remember that. I've seen it. Yeah.
Yeah. And I really like to have fixation of the electrode at the buttress with a titanium clip. So since middle ear and cochlea have the exact size throughout life, we have these 2 points are really stable throughout life.
Yeah.
And especially in children, where you have skull growth and you have looped in the electrode. I haven't seen any electrode migration so far, or as a real problem. Then we use this.
Yeah, I think I haven't used this because in Australia we didn't have access to this, and now in Switzerland, with the technique, I think the 1-point fixation is important. That as you put in the lead, as you're showing now into the mass, it's very important to have a 1-point fixation, because otherwise, again, all these movements get transmitted into the inner ear, with potentially detrimental effects on structure and residual hearing. So I think that's quite important. If you don't have a clip available, what you can do is you can fix with one hand. You can fix the electrode in the posterior tympanotomy, and then you can put in the lead with the other hand, so that to make sure you don't, these pressure transmissions and movement don't get translated into the cochlea through the array. Yeah.
That's exactly a good point. You can also use a little bone dust on these edges in order to support or to prevent the coil from flipping out again. Yeah. This is so. I mean, it's inserted. I think we can close it up, isn't it?
Yeah, I think it's time to close up. Serge, yes.
Yeah. In children, I also use some bone dust in order to get it a little leveled, and also I like to seal the channel with bone pate. And I use 3-nil vicryl resorbable thread in order to properly secure the periosteum over the mastoid opening. And if we revise those children 10, 15 years later, the temporal bone actually is closed, or even earlier, if they have a trauma and the implant needs replacement. So this is quite nice. And we can do several surgeries in the patient throughout his life.
Yeah.
Skin also resorbable subcutaneous suture and non-resorbable single filament. 5-nil, no, 6-nil, 5-nil or 4-nil, depending on age.
Yeah, I think important is a lead wound closure. I also use vicryl 3O for subcutaneous tissue and the periosteal layers. And in children, frequently I use also, single filament mono, resorbable intracutaneous suturing, or even, I've also used the histocryl, the wound glue, which also works well. So yeah.
By the way, when you do you drape the outer ear canal? Because this is totally forbidden in our department, because at the beginning of the surgery and at the end, we want to do automicroscopy in order to see if we have accidentally injured the outer ear canal or the tympanic membrane. So how's your opinion on this?
Yeah, no, we always leave it open. And yeah, in the end, we definitely check for these, sometimes it can happen that you can there's dehiscence in the outer ear canal and or in the tympanic membrane, which then you can repair straight away. So, but I think it's good to check at the end. Yeah, absolutely.
Yeah. So we are almost through. I think there's a need for take-home message, and then we can discuss what to do. So space, light, and landmarks is important to see and travel through inner ear space. And I think what you said, that we should always keep the beginner's mind to, do how you have learned it 100 times and then start thinking of it if you can improve it. But you should have a concept. The concept you have to also argument for. So everything needs an explanation. Whatever what you do, you should have an explanation why you do it like this. And yeah, that's my take-home message. Yeah,
especially for someone starting, it's really getting to know your landmarks, rely on them, make use of them, and then already think a bit ahead. As you get more experience, you start thinking ahead about the light, the trajectory, how am I going to put in the implant, the electrode, all these things. But you're right. I think keep that beginner's mind, keep that open mind, because sometimes we can't do things, or things weren't done 10, 15 years ago because we didn't have the technology to do it or the techniques. And now suddenly we have it, so we can do things differently. So I think it's very important as we evolve to to get better at what we are doing. Yeah, so I think
this picture I have to quote because the source is not there. It was drawn by Jan Helms, my first teacher, and he was also maritime minded. So this is navigation lights through the mastoid bone for those times cochleostomy.
Yeah.
All right.
I think we can open the floor.
Yeah.
Questions.
Thank you very much for your attention.
Thank you.
Gentlemen, very great. Thank you so much. I'm sure there was something for everyone in there, and I definitely learned a lot. Again, thank you very much for your great presentation. To our audience, I would like to also ask to maybe pose questions now. In the meantime, I see that we already got some comments and some questions in. From Mr. Chris Rain, there was a question if you do day surgeries or day case surgeries, or do you do simultaneous at the same session or without closing time?
So yeah, I can.
I wonder if this is you like day procedures basically. I wonder.
Yeah. So the question is whether you do a cochlear implantation as day surgery, and in our case in Switzerland and in Australia, the same situation. It wasn't reimbursed. It's a reimbursement issue. I know in North America it's been done, and I think technically it's doable, absolutely. But I think in our institution or in Switzerland, it's a reimbursement issue as well.
As that's the case, I think the patient needs to be medically monitored. This can be, of course, in a hotel or in a hospital. So whether it's daycare or inpatient. At the moment, I think it's mainly a reimbursement issue. Everything in every country has developed out of reimbursement issues. Maybe a long time ago out of medical reasons, but still then it needed to be paid. Yeah, we have them 5 days inpatient.
Yeah, so Chris, regarding your other question, usually do bilateral simultaneously. Yeah, unless there's a special medical reason or any other, but usually we really especially in the toddlers and then the babies, we do it bilaterally simultaneously. Yeah.
I mean, for the toddlers and for the babies within the first 12 months, if possible, simultaneously. And we also identify more and more old people to do bilateral simultaneous surgery, especially if they have chronic disease on one side. And we do the chronic ear and the cochlear implantation on the other side. In adults and old patients, bilateral simultaneous surgery, you always should keep in mind the balance system, because we don't want to have those patients invalidized by bilateral vestibular loss.
Yeah, I think that's a very important point. So that's why we emphasize structure preservation surgery. It's not about only preserving the hearing, but also preserving the vestibular system. Especially because of that, because we're implanting all these babies with bilateral implants, and we want to preserve their balance as good as we can. I think that's an important point. Yeah. And the adults, of course, as well. Yeah.
Wonderful. Thank you very much. There is another question, and first a comment by Mr. Anand Singh. And if I may read it, thanks for sharing your experience and thoughts. In our implant, so meaning the metal implant, the electrode lead exits the stimulator at an angle, and this angle is meant to help the lead to get into the mastoidectomy. Any suggestion on the distance between the mastoidectomy edge and the implant stimulator placement?
Yeah, as we quoted earlier, we use the petromastoid suture because cranial and posterior to this suture, there's no aeration. Meaning if you have at least 2/3 of the implant housing posterior to this and 45 degrees of the temporal line, you will have no problems to have a cortical edge with a small channel for the exit lead, the lead exit towards the aerated mastoid. And this problem occurs if you place it too far away, then you might have the problem that there's no aerated mastoid next to it. But this is rarely the case. This is sometimes in patients with simultaneous schwannoma surgery, where we want to have the magnet a little further away. But if there's no malformation, these intra-individual landmarks are most helpful for positioning the implant.
Yeah, I think, I mean, it's a good point with that angle, you know, at the lead exit. And I think to overcome that, especially in a sclerotic mastoid, I think it's important to make a deep recess because you don't want any tension on that angle, right? So I think that's the way to circumvent that.
And the second is to fix it to the bone, you know, because if it's properly fixed to the bone, and you will have no force lifting the.
True.
Great. Thank you very much. I don't see any more questions in the chat, and
Can't have another question.
Apologies. There was another question. Again, Mr. Dancing, if I may ask another question, what makes the difference between highly bleeding and less bleeding mastoidectomy or mastoidectomies?
High bleeding mastoidectomy, you always have if there's really bad anesthesia, if you have bad infiltration anesthesia in advance, or if you have infection. So if you use proper local anesthesia, which we always do, if you have a good trained anesthesiologist who knows what you need, and no infection, there's no problem. And I think with the anesthesia, the biggest problem is you say it's bleeding, then they answer, oh, there's no blood pressure. The blood pressure is fine. I say the blood pressure is not the problem. The deepness of the anesthesia is mostly the problem. The patient needs to have no pain. Because the blood pressure doesn't, this is only important if you do heart surgery or abdominal surgery. In cranial surgery, pain is the issue. So the patient needs to have no pain. So we can actually do all our surgery in local anesthesia if the pain is away. Patient doesn't need to sleep, but no pain, no bleeding.
Yeah, good point. Yeah, usually, I mean, we use TIVA, total intravenous anesthesia nowadays, so it's very controlled, and you get hypotensive techniques. They apply that, but I think pain is a real issue, as Rob said. As long as patient doesn't have pain, you can also do open brain surgery. So there's no problem with doing that. So, and Arno Dietz is very experienced in doing cochlear implantations in elderly under local anesthetic, and he is really having very good results. So I think that's very doable as well, especially considering in the elderly. I was thinking about implanting the elderly patients and the effects of anesthesia on their cognition and all that. I think there's quite some increasing amount of evidence that there is an impact. So maybe really reconsider, the local anesthetic technique. That's what I'm thinking about.
That's important. And so sometimes we do lots of stapes surgery, or almost all our stapes surgery we do in local. And we have also a little propofol infetta running, so the patient has no pain.
No pain, yeah.
So.
Yeah. I mean, I only have an experience, I think, a handful of cochlear implantations on the local, and it was nothing special, as we're doing it. Obviously, you had to pay attention to the infiltration, and then, yeah, it goes fine.
That's why a good local infiltration, even in TIVA or general anesthesia, is important. I mean, now with the pharmaceutical crisis, where lots of things are available anymore, we always get, or we sometimes get a new ultra new local with, usually we have ultracaine with sucraline, and then we get something different, and you can see it's not working properly if the correct amount of adrenaline and local is not there. It doesn't work good. So because if you have proper local anesthesia or infiltration anesthesia, then the anesthesia can be also very nice triggered, and especially in elder patients.
Good. Okay. Thank you both so much for addressing all the questions, and I'm sure they were all nicely answered. And thank you very much again for the interesting presentation. And it was actually exciting for the first time, having two very experienced surgeons facing the same topic and discussing and teaching. Thank you very much. So all the best to Lucerne, Professor Rajan. All the best.
Thank you very much.
Professor
It's
Mlynski.
great to be
It
here.
was great
Thank
having
you.
you. Thank you very
for
much.
the invitation.
Thank you. Good.
Bye-bye.
And that brings me to us to the end of today's Surgery Online. And I just wanted to mention the upcoming Surgery Online session on July the 26th is going to be a bone bridge implant surgery in children with complex ear disease, macrotia, and oral atresia. So I would also like to just quickly thank our ICM team that always makes everything possible here in the background. Once again, thank you very much, Professor. All the best, and hopefully we will see you guys again very, very soon. Goodbye.
Thank you. Bye-bye.
Bye.